So this is our Being Black in the NHS event, and I kind of wanted it to be a space where we could talk about just general Black experiences, whether they be from a clinical or professional perspective, or it be as a patient. So I'm very lucky to have Dave Corbin here with us, and just like to clarify that Dave Corbin is not an NHS clinician or a doctor and will not be involved in any clinical diagnosis or medical advice. I really had to make sure that I wrote that down so I'd remember it. So Dave, if you'd like to introduce yourself and what you do.
Thank you. Well, first of all, thanks for the invitation to come and talk here. I've been living in Dorset since 1998. So I've kind of been working in and around this university for some time. So to find myself now sat in this chair talking to a group of students is quite something. So a bit about me really. My name's David Corbin and my family come from the Caribbean, from Barbados. My dad came over in 1953, my mum followed in June 1953, and my mum followed sometime after that, with aspirations of working in the NHS, but that's another story. I grew up in London, North London, Tottenham, Haringey, Finsbury Park area. I am an Arsenal supporter, so just to get that out of the way before we get all the quips in. I grew up in London. It was let's just say it was a difficult upbringing. Being black in Tottenham in the mid-60s and 70s was not the best place to be. Because of the way society was going and the experiences of, in my teenage years, engagement with the police forces. As if I didn't learn from that, after leaving school with virtually no qualifications, I went and joined the British Army. Initially, just to get off the streets of London. And if I look back in history about what was going on in London around that time, with the uprising that was going on in Brixton, in Birmingham, it kind of helped me to understand better why I made that decision at the age of 17 to join the army. I joined the army at 17 and 1 month. Initially it was going to be a 3-year stint just to let things cool down, and I don't know what happened, but it went from 3 years to 30 years. And I finished off my time in the army in Dorset at the Army School of Recruiting in Bovington as an instructor, and I managed to work my way up through the ranks in a cavalry regiment, which they don't really have black people. I managed to get all the way to Sergeant Major, so I was quite pleased about that. Finished my time off 30 years, left the army and went and got a job at Weymouth College as their Equality and Diversity Advisor, and helped them to improve their Ofsted results from being unsatisfactory to good, to excellent, especially around access for students with disabilities. 2 years at Weymouth College, left there as a staff governor, and then I went and got a job with the NHS in 2008. Initially in Dorset Healthcare in their community health services. 2011 they merged and became Dorset Healthcare with the community services and mental health services, and I stayed there until December this year, or last year, sorry, when I was appointed as the South West Workforce Race Equality Standard Lead for NHS England and NHS Improvement, which is the role that I'm doing now in the South West. I cover all of the hospitals, community services, mental health services, clinical commissioning groups, from Southampton all the way down to Cornwall and the Scilly Hills. So I cover all of those, and I'm working with a great team of people trying to look at working around equality and diversity and inclusion for the NHS. So that's a quick sprint through my career, and every one of those chapters could be a completely different session. So I'll leave it at that. But if you have any questions you want to answer about anything this evening, then ask me. If I don't know the answer, I'll be honest and I'll tell you. But if I do know the answers, I'll give you an honest answer as I can do.
That's great, thank you so much. I wrote like a little introduction thing, but I just don't think it's as good. So please forgive me. It was also supposed to be kind of, it's just not good anymore. I was basically going to say, so healthcare has always been an environment that either makes you feel safe or puts you on edge, from long phone queues or to unfriendly faces at reception. However, this experience is made even more difficult if you're a global majority or a person with an ethnic name. People, healthcare professionals, support workers see you before they see what you're actually going through. There are too many black people with negative experiences when accessing support in the NHS, and too many that have lost their lives. So there will be quite a few questions where we can kind of go into discussion about what these experiences are, whether they be anecdotal, whether they be professional, and kind of just talk about how these things impact black people in the day-to-day. So my first question for you, Dade, is what has been your experience within the healthcare sector as a patient?
Yeah, as a patient, I think I would say that it's been, I'm still here. So generally speaking, my experiences have been very positive. I've always got an outcome. Mm-hmm. But there have been a couple of things that have really stood out in my mind around, they just weren't prepared for someone like me to come and use their services. You may not be able to see, but I have got a false tooth. And when I went to the dentist to try and get my false tooth put in, he said to me, well, you can have it in this colour, or you can have it in this colour. So there was nothing in the system that allowed for a gum of someone who was anything other than white English or white British. And I felt, well, I could get one, but I'd have to pay extra. So I thought, well, that ain't very good. So I've kind of challenged that back into the system. And I have had dentists say to me, or make comments to me, oh, you're one of those type of people, which means your teeth are going to be really difficult to manage. One of those type of people. I'm not quite sure what that means. So it's kind of assumptions that are made about people who go to use our services based purely on the colour of your skin. Not because of anything about you as an individual, but based purely on the colour of your skin. So that was a quite, a challenging experience for me to go through. And the other one that I went through is a bit more recent. One of the conditions that BME people or black males do suffer with is diabetes. So I've got to that age in my life now where I get more mail from my GP than I get from anybody else, inviting me for all sorts of tests. So I went and was tested, and they said, oh, you look like you might have diabetes. Oh, okay, yeah. So they ran some tests on me, and they said, well, your readings don't make sense, not making really good sense, but they're going to have to send you for a scan. So I went to go and see my doctor to get the referral. And what was really strange was that the appointment was at 7:30. I was back home at 7:35. So I got there early, been seen by the doctor, who basically had no interest in me whatsoever, and then just simply made an appointment for me to go to the Pool Hospital to be checked. So I went home. I couldn't believe it. I thought that was really, really quite rapid. He wasn't really interested in me. He didn't ask me any real questions. Anyway, but what he did do was he prescribed me some tablets. And these tablets are meant to help your kidneys. I Googled them, as I do, and I looked at them and I thought, crikey, now if I've got diabetes, then this is really good. If I have got a kidney problem, this ain't so good. So I was a bit reluctant to take the tablets. Anyway, hospital appointment came round. I go to my hospital appointment and I see a specialist, and she starts asking me questions about my medication, if I'm on any medication, and I said, yeah, I'm taking these tablets. She said, what's your ethnic origin? I said, I'm from the Caribbean. Oh, they put you down as being African. I said, does that make a difference? He said, yeah, it makes a huge difference. On your score that they give you for your kidney reading is adjusted because of your ethnicity. But if you're not African and you're Caribbean, it means that the score isn't as bad as at first we thought it was. And then she goes, are you taking medication? I said, yeah, I'm taking these tablets. And she goes, don't take those, they'll kill you. And I was struck then that actually, if I hadn't have had that appointment and if I'd have carried on taking those tablets, I could have done myself some irreversible damage. And only because the doctor that saw me made the assumption about the colour of my skin that I was of African origin and not from the Caribbean. And that experience and the way that people are being treated in GP practices, in hospitals, in mental health, the way that that plays itself out is that people get misdiagnosed, they get overprescribed, they get the wrong medication, and all because people make assumptions about people which is completely incorrect. I joined the NHS at a time when the mantra was about patient-centred care, putting the patient at the centre and building the care around them, relating to that individual. And I still say that if everybody did that, we wouldn't be in the situation that we were in. Too many times people just make the assumption about someone based on the colour of their skin, and then they reach for the nearest medication they think is going to fit, which is completely wrong. So that's my two experiences that I will share with you. But my kidney, I say my kidney because I only have one, as they've found out, and it was quite shocking when the nurse that gave me the results said, you need to limit your physical activity. I said, I'm 61 years old, I've been in the army for 30 years, and now you're telling me I should limit my physical activity. It's a bit late. It's a bit late for that. But thank you. But yeah, one kidney, which is amazing. I'm still here. Fine.
Thank you. So moving on to the next question, what has been your experience within the healthcare sector as a professional, considering structural barriers to career progression?
Yeah, so I think I just wanted to break this one down just to try and get you thinking about the context of things. So when was the NHS set up? Year, what year roughly?
1948.
Brilliant. Gold star for that. 1948.
Yeah.
Month?
Ooh.
I know, I'm a stickler for data. July, 1948. Next question. When did Windrush come to UK and dock at Tilbury Docks? What year?
1948.
1948. Very good. What month?
Going to go in July.
No,
No?
it was June.
Ah.
So there you have the first issue that you come across. People from the Commonwealth who saw Great Britain as being the mother country were invited to come to this country to help rebuild it after the Second World War. And one of the things that they came to rebuild was the NHS. They were here 2 weeks before it actually got launched,
Yeah.
in order to get things in place so that when it launched in July, there was going to be people there to receive the patients. A lot of the people that came with overseas qualifications. They weren't allowed to enter the jobs or the professions that they were doing in their home countries. But they were allowed to become healthcare assistants or HCAs, working on wards, doing the bedpans and getting people water, but they weren't able to work as clinicians. Their qualifications weren't fully recognised. But some of them, because of where they'd come from, they still took on those jobs and had to find a way of then re-qualifying when they were in this country. So that was the first thing, 1948. Okay. Next question. How many NHS organisations are there in the UK? Would you guess? I'll go up in scale. 50? 100?
Oh, it's got to be thousands.
217. 217 NHS trusts and clinical commissioning groups in the UK. That's a lot of organisations. Okay. How many BAME chief execs do you think there are in those 217 organisations. Is that 3? Oh, okay, no, a bit higher than that.
10.
Less than 10.
5.
8. 217 and only 8 black chief execs. And 2 of those are endorsing. 2 of those are endorsing. What's happened to the rest of the country? So from 1948 to 2001, 73 years of black people working in the NHS, and they cannot find a way to break through to the top of the organisation in the areas where decisions are being made, where money is being spent, where the allocation of services are being decided. You will find virtually no black leaders. So when we talk about health inequalities and why we're in this state in 2021, talking about health inequalities, a lot of that comes from the fact that there hasn't been the diversity in the people who are making the decisions at the top of the organisation in order to give it the due regard that it should be given under the Equality Act 2010. And therefore, a lot of the things are reported on and people can see them, but there's no real, if you don't put money behind these types of things, nothing will change. And therefore, we've got a landscape now where we've seen these, the inequalities that came out through COVID-19 and the deaths and the impact on different communities that's really shone a light on health inequalities. And I'm shocked that it's taken and saddened that it's taken a national pandemic to bring that spotlight onto these areas. But at least people are now looking at it and people are having to do things about it, and the reporting is going to change in the future, I hope. But it's taken a long journey, 73 years to now start thinking about it. And the reports that have come out, I've got some of them here, that were out before the pandemic. They came before the pandemic. Roger Klein is a researcher, and he brought out a report called The Snowy White Peaks. And the report says what it is in the report about the NHS. The report basically said that the NHS was like a snowy white peak. The higher up in the organisation you go, the less black you'll see. So if you get the chance, have a look at that report, because up until Roger Klein did that report in 2014, there was lots of anecdotal discussions about what the experiences was of black people in the NHS. If I went and spoke to any elderly nurse who worked in the NHS, they would tell you what they experienced. They would tell you about the discrimination that they'd come across from their work colleagues and also from the patients, and that they were never given any support. But there was nothing that actually brought all of that together. So the Roger Klein report was the first time that it actually brought together huge amounts of data about the experiences of black, particularly black staff in the NHS, mainly in London. And it showed that people were increasingly struggling to get career progression. They were increasingly finding themselves in disciplinaries. They were increasingly trying to get promotion and getting knocked back and not being selected for promotion. And they were always ending up on disciplinaries for minor things, while the white counterparts were just being told off. Black people would end up being on the disciplinary and getting a final warning. So the evidence that brought up was the first time that people started to really mirror down onto it. And that led on to a series of other reports that have now been going. And the Workforce Race Equality Standard report's been running for 6 years now. There's been a change at the top in the way that that's being done, which is fantastic. And we've got a new leader on the Workforce Race Equality Standard. His name is Dr. Anton Emmanuel. He's now in charge of it. And rather than just year on year allowing organisations to publish their poor data, telling us that black people were having a really bad time in their organisations, is now said, you've got to do something about it. It's no good just reporting it year on year. We want to see a year on year change. So what are the actions that you're bringing in to try and stop black staff from ending up in disciplinaries? What are you doing about the recruitment and selection process? What are you doing about the career progression of our black nurses in NHS organisations? Because the data is very clear. So in a way, we've moved from just reporting the data to now holding people to account for their actions that they're going to do and monitoring their progress. I still think there's a bit to do. There's another little bit that needs to be done on the end of it, and I think people that don't do it or do it badly should be held accountable. But that's where we're heading. But we've got to put all the steps in place to make sure that we can do that fairly. And people are given a chance to improve. Sorry.
Please do not apologise. You really like snaps because I was like, oh my gosh, like, yeah, please go on. You mentioned COVID earlier, which leads to one of my other questions, which is what has the impact of COVID been on BAME staff / the community, including considering the distrust of the vaccine? And I know that this time has been incredibly difficult for all people, but the way that COVID has impacted BAME, specifically black people, has been ridiculous, but the fact that it's been underreported as well is even more appalling. So, for example, with the report of the French medical professionals talking about rolling out the vaccine in Africa, because there were low reports of people dying, which doesn't make sense in my opinion, but the fact that they almost see us as medical marvels, but they also want to experiment on us at the same time. So I think things like that just show that black people had somewhat of a reason to be afraid, but also this should be a safe space for you to get something that's actually going to protect you, but this has never been a safe space for us to access things like that. But yeah, please, I feel like I should repeat the question now because I went off on my own thing.
No.
What has the impact of COVID been on BAME staff in the community, including considering the distrust of the vaccine?
Okay, so I'll take that question in two parts really, and really from where I was sat when COVID hit and people were forced to stay at home. There was my immediate concern was what's happening to our staff. Mm-hmm. What is happening to our staff and how are our staff going to cope during this period of time? And organisations that had good connections with their staff and managers that had good connections with their staff, a pandemic wasn't going to stop that from happening. So I had examples where managers were going down to the main office in Poole in their car and picking up computers and chairs and taking it round to people's houses to make sure that they were being supported. That they were going down, grabbing any equipment that they could do. They were phoning their staff up almost on a daily basis to make sure that they were okay. And where those connections were built before COVID, COVID didn't destroy them. It only made them stronger. On the opposite side, where those links had never been made or firmed up and there was no trust in that relationship, I had BME staff coming and contacting me saying, I've been at home for a month and nobody's spoken to me. Nobody's contacted me. I don't know what I'm supposed to be doing. My bosses keep giving me jobs to do that I can't actually do. So it was how, supporting those staff to make sure that they was being supported and also nudging the managers to this is real. This is real. This isn't the time for you to go and hide. During my time in the army, I faced a number of real critical incidents, and people who were leaders are seen as still leading. They stay at the front, they rally the troops, they get everyone to do what they're supposed to do. But I also saw leaders that when the first bang went off, they were in the nearest vehicle heading in the opposite direction or hiding in a hole somewhere. And I think some people just don't know how they're going to react when things get difficult. And some managers end up in managers' positions but have never been tested as being managers in those type of situations. So while I can understand why they might do that reaction, it doesn't help the people that are there doing the job. So I was really worried about the staff. The other thing that really came into view was the take-up of the vaccine. It became very, very obvious during the first wave and also partially during the second wave that there was vaccine hesitancy taking place within black communities. Some of it for very good reason, for what you've just mentioned, the fact that people wanted to test them, use it on them as testing grounds, and also because of the speed at which the vaccine was brought in and people's understanding of what they were going to be injecting into their bodies, what was going to be, people just needed some sort of reassurance. And I would say they weren't vaccine deniers, but they were vaccine hesitancy. They weren't coming forward in the numbers that we would have liked people to come forward. So what the NHS did and what we did within the Southwest was we set up a number of regional webinars. And I'll never forget the first one that we did was with London. And we had, I forget the terminology, but someone who develops vaccines and talks about vaccines, but he did a presentation. And there was 190 people on that call. That's how fearful people were. 190 people came on that call and stayed there for 2 hours on a Monday night because they wanted to find out. So from that type of webinar that we had, and hearing and listening to the concerns that people were putting forward, within the Southwest, in fact within the NHS, we put forward a plan to, one, it ain't no good you putting on the 6 o'clock news about you want me to come and take the vaccine. Send someone round to my house that looks like me and show me and talk to me about them having the vaccine, and I might just take it. So that work went on a major scale across the country. I think Manchester was one of the first areas that did it, but it happened in London. We did it in Dorset. I don't know if you heard that the mosque in Bournemouth was used as a centre for delivering the vaccine. So we put lots of things in place because it's a very, very personal decision. And people need to have reassurance that, you know, this thing that you're telling me to take is actually going to do me more good than harm. And even now, today, after the second wave, and we're almost in what I call a third wave of there are still people that are hesitant. There are still pregnant mothers who are reluctant to take the vaccine. And I think, you know, we need more evidence. We need to build up that trust, and people need to hear it almost on a one-to-one basis as why it's so important. I personally have taken the vaccine. I've had 2 doses of the vaccine, and I'm waiting to get my booster and my flu jab. Because I'm going to roll my sleeves up, I'm going to walk into the medical centre and say, yep, get in there. Whack them in, not a problem. Because I see it really that it will give me the opportunity to go and see my family. I've got elderly parents, an elderly parent, should I say, and it also means that I'm not in a position where I'm likely to put other people at risk. So that's why I want to do it. With BME population was Bristol, and yet Bristol had really low numbers of BME people going forward and coming forward and getting the vaccine. So black nurses, without waiting for instruction, decided to go to St Paul's and go and knock on doors and say, look, have you had your vaccine?
Yeah.
Well, I'm not quite sure. Well, you know, this is what it's going to do. So, you know, real one-to-one work going on, 24/7. This is people going out in their own time to try and engage with their communities, to try and raise their awareness of it. And I can understand the scepticism, and I can understand the fear. It's just what's on the other side of it, if I don't get it. Even pregnant mothers are now coming up on the news saying that lady that had twins, if I'd have been able to, I would have got the vaccine because I nearly lost both my twins. I nearly lost my life, and I wouldn't want anyone else who's having a baby to She missed out on the first 9 weeks of those child's lives because she was in isolation, and she says she can never get that back. She can never regain that 9 weeks. Her sister had to look after the babies for her. So, yeah.
Okay. I just honestly could listen to you. Yeah, okay, that's fine. So, because like everything you're saying is really interesting to me, and I keep reading up on these things because they're going to continuously affect us. I feel like everybody looks at COVID as if it's a momentary issue, whether it's in healthcare, whether it's in education. But the long-term impact of this it's immeasurable. It's so hard to actually like quantify in words. My next question was, what needs to happen for the healthcare sector to be attuned to the needs of black staff and the black community?
I think I think black history, when I look at it as a continuum, that there has been moments in our history where certain black people or certain world events have impacted greatly on that continuum, and that has affected change. So the bus boycott in Bristol, Stephen Lawrence's murder, George Floyd, COVID-19. These are all major historical events which have all been a challenge, but they have also provided opportunity for change. And I think the NHS, from the discussions that I'm having at the level that I'm at now, I can see that there's a real willingness for that to change. So the development of career pathways for band 5 and 6 nurses in the NHS, which they never had before,
Yeah.
and steps to remove the barriers that they've been facing. If we were looking at band 5 nurses in the NHS, up until band 5, and I don't know if you know, but the NHS has bandings, and the highest band is band 9, and then very senior manager and directors. So up until band 5, the career progression for black nurses is like that. Across the whole of the country, but specifically in the southwest, it's like that. So they come in, some of them are put at band 2 because nobody understands their qualifications. Then they move up to band 3 very quickly, then they get to band 4, then they get to band 5, and then it stops. From band 5 onwards, you go over one band into band 6, and the career progression goes like that. Goes completely in the opposite direction. Not only does it go in the opposite direction, in some of our organisations in the southwest, they don't appear at all. So you get band 5, 185 BME nurses, band 6, 1. Band 8, 7 and 8, none. 9, none. That can't be right. No way, when you look at that data, can people say that this is okay in organisations. And so, because of the data reports that we've been pulling in, and this opportunity for change, we're putting in structures now to change that, to move the dial on that. And it isn't just going to benefit black nurses. It will benefit any nurse. But predominantly, it's looking at moving the dial for black nurses. So that's across the whole country. And that dilemma of the bands 5 and band 6s, I'm a bit of a data geek. So I ran the report for the southwest. I went, oh, crikey, that's interesting. I ran it for the rest of the country, thinking that the southwest was going to be the worst. It wasn't. The worst drop-off in percentage was in the Midlands. And they've got far more BME people working in the Midlands in the NHS than we have in the southwest. But they had exactly the same dynamics, but much greater drop-off in band 6s and 7s. And that's a real challenge. And our chief nursing officers across the country are all working on that as a project. But that then throws a light on all of the other employment groups within the NHS. What's happening in estates? What's happening in finance? What's happening in allied health professionals? Are we seeing the same picture? And if so, what are you going to do about it? Because you're going to be held to account for it now. So this year was the first year that we've done that level of work. So more work on pinpointing and using the data to affect change, I think, needs to be done. The only trouble that we have is that we're always operating almost a year behind. So this year's report will come out this month,
Mm.
and you basically get between now, from this month until April, to affect change before the next one reporting period will start again. So there's not a big window of opportunity for people to affect change. So we're monitoring the action plans of all of the trusts within the South West, and my role is to support them to put in proper actions and then have proper outcomes. So one thing is the data. The other thing that's going on is we employ around 14% of the NHS is BME. And what we need to be, about 14%. And in some places in the country it's a lot higher. In London it's like 40%. And their curve of band 5 and 6 is exactly the same. So I wouldn't say that, just because it's London that you're going to see a difference. It's the same curve. So we've got all of these people, all these BME people within the organisation, but we also know from the data that they're all in the lower bands. So we are now encouraging the development of staff networks. Every organisation has to have a BAME staff network. Every organisation also has to have a disability network. Every organisation has to have an LGBTQ plus network as a minimum. So within the NHS People Plan, what Prina Rizard has said, she wants to hear the voices of people within the NHS. So putting in place a proper structure in organisations where that voice and those voices can be heard is really key. I think that is already making a difference in the way that people are having conversations about race. The other thing is that we're putting in place is a reverse and reciprocal mentoring program. So I'm working with the top-notch people within the NHS, and they're coming to me for mentoring. So I'm talking to them about what it's like to be black in the NHS and the challenges that I face, informing them about what they should be doing and how their challenges should be being faced and what they need to do to be more inclusive at their level. And that has already had a huge change. One of our directors is recruiting a whole new team. And before he sent out the advertisements for all the job posts, he sent them all to me and said, share that with the BME community, because we want to get applications from the BME community. That would never have happened before. That would never have happened before. So we've got some really firm structures in place that are working, but there are some subtleties around what we're doing as well. We've introduced a Leading for Inclusion program for all of the chief execs. And what is fascinating about that was when we announced that the program was going to be brought in, and this isn't a one-off online training module that someone's going to go through. This is a sit down, let's have a look at your core values, let's have a look at what you're doing around inclusion and what the barriers might be for you to do more. So our chief execs across the whole of the South West are now engaged on that program, which is going to take about a year for them to do the work that they're doing in order to change their way that they're being inclusive. And then that means that from the top, working down into organisations, you're going to have people who are really attuned to cultural inclusion. Whereas before they kind of get to that position, it's everybody else's responsibility, not really theirs, but now we're saying it's their responsibility. The take-up of that has been really, really positive. The impact so far, we're only 2 sessions in, we've got another session in November, and it's starting to impact. I can tell by the language when people come and speak to me that it's starting to impact on the way that they're thinking and the things that they're doing, which is great, because you shouldn't automatically not have any responsibility for this agenda because you're at the top of your organisation. You need to demonstrate the behaviours that you want others in your organisation to actually be showing. Otherwise, you're giving them an excuse not to. So that's kind of the stuff we're doing.
Thank you. It kind of connects to some of the things that you were saying, but What are the other negative experiences of black staff? Excuse me, let me try that again. What type of negative experiences of black staff having to deal with in the Southwest working in healthcare?
Yeah, I suppose I could talk about a few cases. I don't want to identify any particular organisation because I think that would be unfair. But we have had difficulties with our international nurses, people that come from overseas to work in the NHS. Some of the difficulties I've mentioned or talked about is recognising their qualifications. We need to make that sharper. We need to make that easier for people who are under pressure in a recruitment process to be able to check and mirror what qualifications are they're bringing to what they need to have in the UK, so that we give them the proper jobs that they should be going into. You know, we have people who have done extensive work in their own countries come to the UK and then they start them off as a band 3 or a band 4, and they should be much higher.
Yeah.
And then they have that whole difficulty now of trying to fight their way through to get to the position where they should be in the organisation. And sadly, one of the areas we're focusing on is retention, because we know that people come, but they don't stay. If they're having a really bad time, there's so many social enterprises out there and private companies for people to go and work for, that they're gone. And that's a loss to the NHS, a loss to all the money and time and effort they put into bringing people here, if they're not then received properly within their organisations. We've had difficulties where local inductions of international nurses, or in fact anyone who came from outside of the region, to come and work in the Southwest. If somebody said to me, right, you're going to go and work in Dorset, there's a few things I'm going to need to know that are going to make it easy for me. They're going to say, don't go and live in a village. There ain't no buses, there ain't no trains, you ain't going to get nowhere quick, you're going to be sat behind a tractor. So it's not so much about the job I'm coming to do and the environment I'm going to be working in. I need to know more about that pastoral care, that bubble of which I'm going to be sitting and operating. Remember that, putting the person at the centre. What are the things my kids are going to need? What are the things my husband's going to need? What are the things, schooling, dentists, doctors, travel? How easy is it going to be for me to get my hair products? So you know, don't bring me down here and stick me in Blandford, in the middle of nowhere where there's no train station. I need to know what's going on. So that local induction and that local information, that little pack that people should be getting. Welcome to Wool in Dorset, which was where I used to live, and the black population was 0.001%. That was me. There were no black people.
I don't even know the area you're talking
about.
No,
don't. Yeah, drive through it, just keep driving. So now I'm living in Parkstone, much more multicultural. I'm happy. I come out of my house, I see black faces, and I'm like, yeah, this is good. I'm happy here. So, but it's that level of detail now that we need to be looking at. And one of the things is we must learn from other areas that are doing that well. London have an overseas package of induction for overseas and international nurses that have been running for years. I know they have because my auntie put it in place. So why don't people in Dorset who are going to be doing international recruitment go and speak to people in London, pick up the phone, call them and say, we're going to be doing this. Any advice? What should we be doing? What should we be putting in place? What are the things we should be mindful of? Another experience, international nurse that came over was put into a quarantine because of COVID-19. So they come over, we've got them to this country, and they're now in quarantine for 14 days. They have to pay for their own food when they're in quarantine. They didn't bring any English money. They have to make their own phone calls. They've got a phone, but they ain't got an English SIM card. So they can't phone no one. And the manager of the department who's brought them over has gone, do job done, you're here now, we'll wait for you to come out of quarantine and we'll do the rest. Completely left the person on their own. Just consider what that experience is going to be like for that nurse. What's going to happen when they come out of quarantine? And what sort of message are they going to send back to the people they've left behind in their own country? That ain't going to make people want to come forward and want to come to the NHS. That isn't going to want people to want to stay and work for that trust. And that's going to force people away. And I suppose the one last example I'll give you that we've been dealing with is organisation bringing international nurses over. Yes, for the first 2 years you get accommodation through the NHS, that's all sorted. After the 2 years, you're on your own. So it's a bit of a throwback to some of the areas in the southwest, to what we saw in London in the 50s. They won't give accommodation to black faces. And the organisation basically says, well, it's your problem. You need to go and sort that out. And then they're surprised when that person gives in their resignation, the notice, and go and move to somewhere like London, where there's a better or larger population. So they're the things we need to be doing better. They're the projects that we are working on at the moment. And I think my role is engaging with the BME community, both in the NHS and those not in the NHS, puts me in a good position to make sure those voices are being heard around the tables where there isn't any BME people. So that's what my job.
Thank you. My next question is, how do we engage academic staff in this discussion? Obviously, we're in the setting of university, and I think with being in Bournemouth, with being in Bournemouth as well, obviously our staff generally expect our student healthcare practitioners to mainly be engaging with white people or white patients. And I think a lot of the time it gives them an unrealistic expectation about the way the world works. And once they are out in the world, if they decide that they don't want to stay indoors, they're rattled basically. And so how do you think we're able to engage academic staff in this discussion so they can better prepare their students to be, I guess, proper professionals in the real world?
I think things like this are fantastic, to get people together, to come and talk. Tap into the Chief Nursing Officers network if you can do. Get nurses to come and speak to you, senior nurses. I could name drop a few people at Dorset Healthcare into your in-tray that would come and explain to you about what it's like. I think it's not just about working in healthcare, I think it's working in the different departments within healthcare. So working in mental health, working with children, you've got to hear it from the horse's mouth about what it's like to be BME and working in those environments. We still get experiences of black nurses where white patients don't want to be touched by them and calling that out. How do we support both the staff member and also some learning for the patient?
Yeah.
It needs to be done in education and training for the patient. We did end up having to send a letter banning someone from one of our hospitals because of the way that they spoke and treated the black staff in the hospital. And they went all the way to the European Court of Human Rights and lost their case. Get out! Go and find your treatment somewhere else. And that's the kind of levels that we need to be prepared to go to in order to get the message across to the communities and also to the support of our black staff. That's the kind of things we should be doing. So for me, engage. Go and speak to people, go and find out. So I don't know if anyone has capacity, but the Clinical Commissioning Group has a patient engagement group. So if you can get on the patient engagement group, you can go and find out what's going on at the Clinical Commissioning Group in Dorset and join their meetings and find out what's going on is a good way. But the Dorset Healthcare also has a patient engagement group. And you can join that as a layperson, but you can go, it helps you, it puts you in a good position to hear what's coming down the line and how you can get involved and help to shape that and bring the messages back into the university. I think the university has done a great deal of work. I think your population, and I would check this as a challenge back to the university now, go and have a look at your population, go and have a look at your lecturers, and find out what that profile is, and come back and tell me, what are you doing in order to change that profile? What sort of things are you going to do to make sure? How far are you willing to step into the discomfort around conversations of race to ensure that your students get as much inclusion and diversity awareness as possible? When I was at Weymouth College, one of the departments was the hairdressing salon. And of course, everyone that went into the hairdressing salon as a student ended up cutting white people's hair. And I said, well, what about the black people? When are they going to? Oh, we haven't got any models. And what have you done to get models? What have you done to try and get hold of some people to come forward for your students? Because when they leave here and go out onto the, that's going to be the place they're going to be working in. That's going to be the environment. So you've got to make it real for them. And I think grasping that opportunity to, especially now, while conversation is so hot and everybody wants to talk about inclusion, it's a fantastic time to embed that into the university in a way that 10 years down the line you'll look back at this and think we helped put that in place. Remember that continuum. We're only here for a short space of time. And I want to have the biggest impact possible on the people who I'm working with and who I'm working for, and leave a legacy so the next generation of people can stand on my shoulders as I have stood on the shoulders of people that have gone before me. Because that's the only way we're going to make a lasting change in all of this. We need to be consistent and we need to be persistent, but we also need to do it with a smile.
I have a separate question that isn't on here, and I hope that my fellow officers don't mind asking, but we are regularly in places where we are the only black people in the room, and we're the only black people to answer some of the questions that they have, and that can be incredibly taxing and that can be tiring, but you also have the realization that if you don't speak then nobody else will. But how do you find it as a professional that's been in this field for such a long time? How do you find the energy to keep going and keep answering ignorant questions? Because you just get so tired. You get so But yeah, how do you find the energy to keep going after all this time?
It's a question that has come up quite a few times, and I think the thing is that you need to find your inner resolve. You need to be true to yourself. You need not to give up on those core values that make you the person that you are. I didn't get to be a sergeant major in a cavalry regiment where they had no black people without facing huge amounts of discrimination. Huge amounts of discrimination and assumptions. Oh, the black guy's here, get him in the gym. Oh, the black guy's here, he must be a good boxer. The black guy's here, he wouldn't want to be promoted. And every time I came up against that, even if I wanted to go to the gym, and I love my sport, I refused to be pigeonholed, and I refused for people to make assumptions about me. So I went away and I educated myself. I went and I learned, so I understand what it is I want, why I want it, and how I'm going to get it. And I'm not letting anybody or anything get in my way. I'm a tank commander. If I can't go through something, I'll go over it or I'll go round it. But I ain't stopping. It may take me a little bit longer to get where I want to get to, but I ain't stopping. So my advice when you find yourself in those situations, especially if you get asked questions which could be seen as microaggressions. Can I touch your hair? Oh, your skin don't come on. Oh, you don't need to comb your hair because it's already combed. Oh, you don't need to, or your hands are dirty. All of that kind of nonsense that people get, low-level microaggressions. I find that sometimes I use humour to throw it back at people, and other times I will make a stance and I will challenge it. And I'll say, what do you mean by that? What do you actually mean by that? Because the last thing that people who use that kind of terminology want is for you to be professional in the way that you then go back to them. So I often reframe things that people have said to me. When somebody says something like, "Oh, you must be used to the summer," I say, "Why would I be used to the sun? I was born in London." I was born in London. Is it any sunnier in London than it is in Dorset? I don't know. Why would I? Or, "You don't get sunburn." How do you know? How do you know? I've been out in the sun, I burn, trust me. And it peels, and it itches. So how do you don't make assumptions about people? If you ask me, "Are you used to the sun?" I'd say no. So you get the same response. You get the right question. You get the right response. When people say to you, "Where are you from?" and I don't know how many times they've said it. "Where are you from?" "London." "Where are you really from?" "I'm really from London." "I'm really from London." No, you know what I mean. "Where are you from?" I was born in London." I'm not sure what you want me to say. If you ask me where my family came from, and I made a point at the beginning, my family come from Barbados. And if somebody said to me, "Who are you?" I say I wouldn't know. Because my dad was born in Barbados, my granddad was born in Barbados, my great-granddad was the first person in our family that was born a free man. Other than that, they were slaves. So I have no idea where my family comes from. Somewhere in Africa, I'm guessing, but I don't know where, and we can't find the records. So when I watch those programs on the television, people going back into the 16th century and tracing their history back to King Edward I, I'm like, I can't do that. And that's a legacy of what situation black people are in, that many of us, go back 3 generations and then that's it. We're back in the sugar plantation cutting sugar cane. There's no records. And what's sad for me is that I now live in Dorset. It wasn't planned. And Drax Estate is in Dorset. And Drax was one of the first people in the country to set up a working sugarcane plantation in Barbados. And in Barbados, there is a Drax Estate. It's still there. So, I don't know how I've ended up here, but it's like, it's almost like I've come back to pay Drax back for all the things that they did in my country. But there.
Thank you so much. There were other things that I wanted to touch on as well, but I don't think that it would even do justice to it now. Because so there were a couple of things just about just as like a patient, like a black person having to exist in healthcare and having to try and get access to support, and like you were speaking about your experience earlier on, I feel like a lot of the time we have to claw our way through just to get our voices heard or for people to actually take us seriously. And I think it's really fortunate that someone actually recognised what was said on your chart and who you actually are, to see that this is not this isn't the care that you're actually supposed to be receiving. But there are so many people that don't get that opportunity, and it's so unfortunate. So you've got one of my examples was black women and their symptoms during childbirth and how they get overlooked, and too many black women in my life that have gone through childbirth and haven't made it purely because I think something as simple as monitoring blood pressure wasn't recorded, and by the time they'd figured it out, it was too late. And this is during something that's supposed to, for most people, is a luxury moment in your life. This is an opportunity for you to bring life into this world. Obviously, it's not for everyone, because I'd never say that, this is something that everybody has to go through. But childbirth is one of those things that they say is a tick box for existing as a woman. And if they don't monitor that well for you, then that's something that could possibly take away everything that you've existed for. It's a lot. But those are just some of the things that I wanted to say. But,
so I was just going to say that one of the issues that we have tackled and put in place change. Because all of what you said is true across the whole country. that those kind of assumptions again are made about black women, that they can take more pain than anybody else. You know, they can manage. They can't really be in pain.
Or you're strong.
You're strong. Yeah, they're strong. They can take it. And for black men in mental health settings, the terminology that I came across was that black men were big, black, and dangerous. Therefore, when they go into a mental health institute, rather than being met by a receptionist and a nurse who's going to, you know, bring you in and take all your details and find you somewhere to stay, they get met by an army of people who wrestle them to the floor and drug them up and then put them away. And anyone who listened to Frank Bruno's experiences of going into mental health can justify it, because they gave him so many drugs he fell over and nearly broke his elbow. So it's that kind of assumption which is really, really negative and still needs to be challenged, based on very, very poor science. Is why people believe that, and that needs to be challenged. And yes, but one of the things that we have worked with, again I won't mention the area, was that a number of BME women were announcing that they had been told after their scans that their baby had anomalies, and the chances were that the baby was going to be born with autism or a disability, and their advice that they were being given was to get rid of the baby, to terminate the pregnancy. And this was a constant message, and it turned out when we looked into it, it was only being said to the black women. So we went in and challenged all of that. That doesn't happen anymore, no longer happens anymore. And of course, they would justify it by saying, well, we give this kind of advice to everybody. Maybe not as strongly. There's different ways of saying it. There is a small chance that your baby may have an anomaly, or you need to get rid of that baby. It's a different kind of conversation. So we've challenged that, and that no longer happens in that particular department. But that's the kind of, you know, you have a voice. One thing that I'm very, really conscious of is that not very many black people complain. And in the NHS, it's sad to say, those with the biggest voices get heard and get seen. So even for me, when I was waiting for my kidney check, I was phoning up. They must have get, oh, it's him again. Yeah, Mr. Corbin, yes, we'll get to you. Yes, we've got you down on the list. I said, I'll take any appointment, any cancellations, just let me know and I'll be there. Yeah. If you don't hear, don't wait. Phone up. If you get told something at the doctor's, don't accept it as being the only option. Ask them, what else could I do? Is there any other medication I could go on? Is there any other treatment I could go on? When I got diagnosed with type 2 diabetes, they wanted to give me medication. They wanted to put me on tablets, which I would have been on for the rest of my life. And I said, is there anything else I can do? She said, well, you can change your diet. Done. I changed my diet. I'll drink water. I'll eat more fruit. I'll still have a rum every now and then, but I'll drink fruit. And after only 3 months of that, I completely changed I'm no longer type 2 diabetic. So you have to feel comfortable in your own self and just ask the questions. Don't just be accepting of what people tell you. My parents would have done. They would never have questioned anything anybody in authority ever said to them. I think we're in an age now where we owe it to ourselves to just question. Are you sure that's right? Should I be? Is there any other medication I could go on? What's the side effects if I start taking this? How long am I going to be taking this for? Because it's all too quick that people want to give you medication when actually you have alternatives. If you don't ask, you'll never know.
Thank you so much. Just for everything. I appreciate you coming here and answering very long questions, and I appreciate you sharing your experience as well. Does anybody have any questions for Mr. Corbin?
I'll answer anything.
Is this going on online?
Yes, if that's okay. I feel like it's probably a bit too late for me to ask if that's okay. camera has been rolling, but if that's okay, then yeah, it'll be going online. I'll also be sharing it with James Parr from UK as well.
Oh, brilliant.
And hopefully it will roll out with our podcast too.
Brilliant.
So yes.
So you've got Laura coming next week. Is it next week?
I think so.
Yeah.
Yeah.
I'm going to try and dive into that as well.
I have a question.
Yeah, certainly.
Hi, everyone. My question is, how do you think that like non-black and non-BAME people can like be allies to like black people in the NHS?
So our allyship programme is going to be launched towards the end of the month. And we've already started working on allies. And it's surprising when I do my allyship presentation, the questions I get that come back from our non-BME staff about, I want to do something. I want to get involved in this agenda. I've seen the social injustices. I've seen George Floyd. I understand what the data's telling me. I just don't know what to do. I just don't know what to do. What do you want? How can I help? What can I do? So I say to them, the first thing you need to do, get yourself immersed in some of these reports. Go and read about the experiences of black people in the NHS. Learn about the experiences of black people in the community. One of the things I said this morning was, when I grew up, I got to know all about Bobby Charlton and the 1966 World Cup. Nobody told me about Arthur Wharton. Nobody told me about Mary Seacole. Nobody told me. You know, I've got everything there was to know about Florence Nightingale. Why wasn't I being told about the black people who had also achieved great things and set national targets and goals? Why wasn't I being told that? Why am I now only just finding out about the women at NASA that helped to put spacecrafts into space? Why am I only just finding, and it's that kind of deficit of knowledge and information that we need to be asking questions about. So people who want to become allies, I'm not saying I want you to come and walk in my shoes, because they're pretty big shoes. I've got size 10 feet. But I want you to come and walk alongside me. I want you to hear my experiences. I want you to know what it feels like when somebody asks you where you're from, or can I touch your hair? I want to know that when I'm not there, in those areas where there is the senior discussions taking place, when I'm not even the only black person in the room, that you are going to stand up and say, what about black people? You're going to bring that agenda to the table and you're going to represent me in those areas. And to do that, you need to be able to do more than just say, yeah, Black Lives Matter. There's a bit more that you need to commit to. And when people get involved in that and start doing that, then that's when we're going to see a cultural shift. But we can't do it on our own. Women fought for the vote. Men made the decision for women to get the vote. Black people have fought for slavery, to end slavery. White people made the decision to end slavery. So if we're going to stop racism, and we're going to challenge it, while we can lobby and while we can speak about it all, especially within the NHS, we're going to need those people at the very tops of the organisation to actually change it. And if that changes, we'll be in a better place.
Does anybody else have a question?
Certainly.
What is the one thing that you wish you started doing earlier?
Feels like a loaded question.
It is. I don't know. Drinking rum? No. No, I think when I look back on my time, I wish that when I was younger and at school, I'd paid more attention. Not just to the subjects, but to the things that weren't on the table as being discussed. I just wish, because I went through school being left-handed and dyslexic, and for the first 4 years while I was in school, they kept putting the pencil in my right hand and couldn't understand where I started off writing at the top left-hand corner of the paper and finished off in the bottom right-hand corner, and I couldn't even read it, and I was slow. So I never really took to education. I think I wish I'd tried to get myself educated to a better level earlier. 62 now, and I'm still learning. And I still do training courses, and I still go and find out about things. But I think that grounding of having a good education and an inquiring mind is something which is invaluable. And all of the speakers that have come and spoken to us have all spoken about not just the fact that they found academics challenging, but the fact that their parents supported them to push through and get on and get their education because of the need that, you're other. You're going to find it difficult if you don't get a good education. So I've had to work hard in latter life, probably towards the end of my army career. I went and done courses to get myself qualified to be in the position I'm in. And it just kicks back against all the people that told me at school that I was stupid. I wish they were here now. Look at me talking at Bournemouth University. I'm very proud of myself. Any other questions? Yes.
Lovely. I'd like to know where you'd like to see the NHS get to in relation to racial equality in the workforce in sort of the next 5 years.
I don't know if I'm going to be around for the next 5 years, but I would like to see it in a place where the things that we're putting in place now can make sustainable change over a long period of time. I don't want it to go back to what it was before, where people were almost being colourblind, and the stories and the experiences were shoved in a corner when no one looked at them or nobody dealt with them. So we have the platform now to really make change. I believe that we've got a strong enough national team with Prina Rissard and Jenny Douglas Todd, with those kind of people leading this from the top of the NHS. We have no reason to say, well, this is going to fail. They're not going to allow it to drift away, and as long as we can maintain a focus. The one thing I will say is that being in a position like this is challenging. Your emotional well-being you need to be careful of. You need to watch out for things for yourself. You need to obey the signs. So I talk about drinking rum. I'm going to a rum festival on Saturday in London with my brother, and we're going to drink rum, and then we're going to go back to his house, we're going to eat chicken, and we're going to play dominoes. Because that's what we do. That's my release. That is my way of connecting, reconnecting with my family and with my friends. You need to find out what works for you. If it's a walk in the park, a swim in the sea, a cycle ride, cup of tea, a stroking your cat, walking your dog, it doesn't matter. Whatever it is that makes you feel good, make sure you find the time to do it. And in 5 years' time, I want to be retired next to a shack somewhere on the Caribbean, sipping rum punch, thinking I've done a good job.
I think that was a fab answer. Can I ask what brand of rum?
Oh,
I don't know if we should pause the camera.
you're really asking me now. So, if I have a favourite, I don't have a favourite. I just like rum. So, Diplomatico is nice. I try to stay away from Bacardi because even though they come and they have a stall there, it's nice, but not that nice. Diplomatico's good. Fleur de Canio's lovely. Red Leg. Monkey's Finger.
Because Red Leg is like my.
Really?
Yeah. Okay. Okay. I'm not upset with this.
Well, listen. If you ever get the chance to go to a rum festival, and don't go to one at Bournemouth, you've got to go to the one at London, because once you get in and you walk around with your little top glass and you've had a few rums, and they start playing the music and then the dancers come out, it's the best way. It's just the best way to spend it. The first time we went there, we met people. Because we met friends with everybody. Everyone's having a great time. We came out, went to the train station, and these people that we met all got on the train and it shot off, and we went goodbye, got on the other side of the platform, waiting for our train to come in. The train came in, it wasn't one that we wanted, and all the people got off again. But they got on the train going the completely wrong direction, so they went 2 stations down and came back. So, but it's anything you can do. Walking, I love walking around the hills in this area, I love walking down the beach. Anything, listening to music, put music on, loud. But find a way of reconnecting and grounding yourself, because that's where you find the inner strength to continue with the challenges you're going to face on a daily basis. And it ain't going to stop. What you face this week or next week will probably be replaying again. So you need to ground yourself. I think there is something about knowing when to challenge and how to challenge. Because if you challenge in a good way, you'll get a good outcome. If you travel from a bad place, you just escalate things.
Can I ask what advice would you give a student nurse who's experienced racism on her placement?
Sadly, that's one of the biggest things that we have seen at the moment. We've got a very, very well documented case that we use in training now. The first thing I would say is complain. Do not be afraid to complain or to expose the people who have put you in that position. The second thing I'll say is it's not your fault. The problem does not lie with you, it lies with those others who have put you in that position. And what you need to do is to find out who is the go-to person in your organisation for support. We have freedom to speak up guardians in the NHS, of which I am one. I'm trained as a workplace mediator, and I'm also trained in dealing with conflict management. And you'll be surprised how many people come to me who have experienced challenging situations and don't know how they can deal with it. So I think there has got to be a process in there that you can report to. There are people that you can write to. Ensure that everything that you do is documented, is written down. It's no good going into conversations with people and them telling you that they're going to do something about it, and then 6 months later you going to them and saying, you said you were going to do something about it. If they don't write it down, then you write it down, and you write it down in a way where, thank you very much for the meeting today. At the meeting we discussed this, and you said you were going to do this. Hope this is a true record of our conversation. It's as simple as that. Because when things are written down, people are more unlikely to go against them. They will want to see them through. And they also know that that written record is something that they will be held accountable to. Too many conversations in corridors, too many they said they were going to do this, and then nothing gets done. And then when you go and challenge those, well, I never said that. I never said that. You never explained that to me. You never said that that was the case. So you need to make sure, put it down. And if you want any support, got my email address, contact me. Because it's what I do all the time. And not just for BME staff, for all staff.
I can send that over.
Don't suffer in silence. Speak up.
So my question is about, so the NHS obviously has had historic problems far too long. The worry for me is obviously above that you've got the political situation, which has kind of driven so much of the problems, across society, NHS being part of that. Do you have any confidence that there is the willpower from the government and the health secretary and the department itself to affect a lot of the changes that need to be made? That's quite a big question.
It is. I was going to say, don't record this, but I don't mind if it's being recorded. I think in my lifetime I have experienced things from the police as a teenager. I've experienced things from the police living in Dorset, to the point where I went and became part of their independent advisory group, thinking that I would be able to help to support change. And even last night, the new police inspector for Dorset gave a presentation about hate crime in Dorset with Dorset Race Equality Council. And I came off of that call feeling nothing's changed. I've been in Dorset since 1998. Nothing's changed. I don't know how many inspectors have come and spoken to us and told us they were going to do more focus around hate crime, but nothing's changed. You look at the Stephen Lawrence inquiry, you look at police who feel it's okay to rape, murder, sexually assault, and then around them the walls of support close in, and they do their own internal, no, don't do that, mate. Until something like the tragedies of the murder come out. Do I have confidence? I don't think in my lifetime I'll see that majorly change. I did think that as a youngster growing up that I would see change. There may be small changes along the way, but again, I think there's a bigger challenge in society to accept that things need to change, and then when that happens, you know, the Berlin Wall will come down and things will change. But while they are left to make their own inspections of their own crimes and manage that internally, I can't see it changing. I think during my 30 years in the army, I can look back and think that actually I made a difference while I was there, because in the armed forces, black people weren't allowed to be on horses outside Buckingham Palace. They weren't allowed to join that regiment or the regiments that did that particular job. And before I left the army, because I was working in army recruitment, we changed that. We also changed the way that women were treated in the army. Because women, if you got pregnant, you were given £100 and you were kicked out. So we changed that. We made the army stand up and obey the maternity employment law and retain women, and they could have children and stay in the armed forces. And it changed the rules around LGBT, transgender, civil partnerships. So it didn't move easily, and it took a lot of encouragement and support, but we did get those changes done. So I was very, very proud to be outside Buckingham Palace when the first black people were on horseback outside Buckingham Palace. And I don't know if you've seen the Queen's emissary at the moment. He's a black guy. You wouldn't have seen that not so long ago. So it can change. And sometimes it starts off with a small spearhead of change happening. But then actually it then opens out and it becomes normality. It becomes part of everyday business, and people are no longer having to fight to get into different roles because they're open for everybody. I'm really going to have to go.
Yeah, no, that's perfectly fine, because I know you've got another commitment. But thank you so much again for coming, and I really, really appreciate it.
No, thank you very much. I have an appointment this evening with Dorset FA. I have been appointed a director. And tonight's my first annual general meeting, so I don't want to be late, but thank you very, very much.
Thank you so much for coming to speak to us.
Just keep looking up, build your networks, support each other, and keep looking up. And never, never sit back and say, because of somebody else's will, I ain't going no further. I ain't having that. I'm going on. I'll get round you. Watch out.
Thank you.
Thank you very much.
Okay.